All right, good morning. It's 11:32 and we'll get started. I'm Vincent Atchity. I'm the president and CEO of Mental Health Colorado, and welcome to our monthly reports and updates meetings. We've been hosting these for, close to 2 years now on this Thursday of the month so that the Colorado allies and partners who are working in one way or another to disentangle mental health and criminal justice have a chance to learn about each other's work and ask questions. We have made a consistent effort to be very respectful of everybody's time and make these compact meetings that will end by 15 past the hour at the latest. And what we do is we begin with a presentation from our guest presenter of the month, and then have some time for other updates or questions if anybody's got some of those. So with that, one more thing I'll mention, I'll put a link in the chat in a moment. All of these reports and updates meetings are recorded, and the whole library of them is available on our website in case anybody wants to refer something they heard along to somebody else. All right, with that, it's my pleasure to introduce Dr. Sarah Axelrath, who's the primary care and addiction medicine physician with Colorado Coalition for the Homeless. Thank you so much, Sarah, for joining us today. And please go right ahead and begin your presentation.
Well, thanks for having me. I'm very excited to be here, and I'm a big supporter of what this group does. So it's nice to see so much representation from allied organizations across the state. Give me a second to share my screen here. Okay. All right. Ideally, everybody should now be able to see my screen. Is that coming through okay?
Yes.
Great. Okay, so I'll get started right away. I am going to give about a maybe 15-minute overview of Colorado Coalition for the Homeless and some of the things that we do. I'll talk a little bit more specifically about my work in addiction medicine and street medicine, as I think that those overlap and dovetail nicely with the mission of Mental Health Colorado. And then I'll leave a little bit of time for questions at the end. So I'm Sarah Axelrath. I'm an addiction medicine and street outreach physician at Colorado Coalition for the Homeless. The mission of Colorado Coalition for the Homeless, which is a nonprofit founded in 1984, is to work collaboratively towards the prevention of homelessness and the creation of lasting solutions. And we do this in a multitude of ways, which I'll cover in a bit. But the highlights of our mission include permanent supportive housing for a diverse subset of Colorado people experiencing homelessness, and integrated medical and mental health care for people experiencing or at risk of homelessness. So just a very quick overview of homelessness in Colorado. I'm not sure how much background you guys have in this topic. Every year, the Federal Department of Housing and Urban Development, or HUD, does a point-in-time snapshot of all of the homeless demographics and populations of every state and major city in the country, or every city that participates, which Denver does. And they essentially do a survey of people experiencing homelessness. They send out volunteers on a given night every single year into the community to count and try to access and quantify the number of people, individuals, and families experiencing homelessness in the United States. So we'll go through a couple of those statistics. Just as a sort of benchmark, in 2020, there was an estimated 580,466 people experiencing homelessness across the United States. So 500,000 people, and for various reasons, that's thought to be a significant undercount. In Colorado statewide, we have close to 10,000 people homeless on a given night. That's from 2020. Again, we think that's a significant undercount. There are certainly people experiencing homelessness in places in the state where we're not able to access them with any regularity. So we think that's an undercount, but by how much is not totally clear. COVID changed those counts a lot, which we'll get to in the coming slides. And as you can see, the bulk of homelessness in Colorado is centered around Metro Denver, although other counties and other parts of Colorado certainly do experience homelessness, but possibly on a less scale and with less visible density. So in Colorado, according to the National Alliance to End Homelessness in 2018, there were about 7.5 individual adults experiencing Colorado, which was a significant increase over the past 4 years since 2014. There were a number of families experiencing homelessness, over 3,000, which was a decrease since 2014, which may reflect some of the successes that we've had specifically in building programs to house homeless families. There was a significant number of youth, 600 experiencing homelessness, and then veterans, 1,000 veterans experiencing homelessness, which unfortunately has been increasing over the years. Chronically homeless individuals in Colorado, about 2,700, and chronically homeless is defined as having been homeless for 1 year or more. And what we certainly know is that the longer time that you spend homeless on the streets, the harder that it is to reaccess housing for a number of reasons related to vital documents and the general disorganization and chaos that comes with street-based homelessness. And so Colorado Coalition for the Homeless, the main thing that we do is we house folks experiencing homelessness. So 22,000 people experiencing homelessness have been housed through us, 2,000 families. Of course, we house people of, any demographic that we can, and we specifically do have a number of programs that work to house people experiencing serious and persistent mental illness and folks who are heavily involved in the carceral systems. So we have a number of ACT teams, or assertive community treatment teams, which do specifically work to locate and house people experiencing persistent mental illness and to, importantly, keep them housed. And we are also the recipient of a 2016 Denver City Social Impact Bond, which helps us identify and target people who are experiencing homelessness and have had frequent contact with carceral systems in order to mobilize resources to get them housed and stabilized. And we've had very good outcomes over the years. About 94% of the people that we've housed have remained housed, and that is a very labor-intensive process. It takes a lot of work and a lot of effort by multiple teams to get people housed, and that's where a lot of our resources do go. And then what happens after that tends to get less attention. So it's equally resource intensive for us to keep people in permanent supportive housing. We have saved $19 million to Medicaid. That's through our Stout Street Health Center, which is where I work. We provide integrated, free, accessible medical, psychiatric, dental, and vision care to people experiencing homelessness. They do not need identification. They do not need insurance. We are able to see anybody regardless of insurance or payer status, regardless of documentation status. We provide healthcare at Stout Street Health Center, which is at 21st and Stout downtown, as well as through a number of shelter-based clinics within our permanent supportive housing units, and then on the streets, as I'll talk about a little bit. Some ancillary services that we provide some vocational services to help folks who are able to work find work in their chosen field, in the field where they have experience and feel that they can make a meaningful contribution and make a living wage. And then we run a Fort Lyon recovery program, which is a long-term residential substance use disorder and co-occurring mental illness recovery center, where people can be referred for long-term treatment and sober living. So just a little bit about why homelessness happens. We won't get too into the weeds on this. In my experience doing this work, if you ask an average person what causes homelessness, they are most likely to first identify many of the individual factors, such as mental illness, substance use disorder, irresponsibility, laziness, that they feel may lead to people becoming homeless. The truth is, though, that while those individual factors do play a role, they may make some people more vulnerable to becoming homeless, or may make those people more difficult to rehouse. The largest underlying causes of homelessness are largely systemic, related to the things that you see here. Greg Colburn, who's a professor at the University of Washington College of Built Environment, has conducted a lot of research into why some societies, why some neighborhoods, why some areas experience higher rates of homelessness than others, and has found that it's almost entirely explainable by availability of affordable housing. Some of the personal barriers that do cause people to become more vulnerable to becoming homelessness are listed here. Certainly, if you have a significant history of trauma or severe persistent mental illness, if you're struggling with a severe substance use disorder or a physical disability, if you're fleeing from domestic violence, those things can significantly increase your chances of becoming homeless within the right societal context. And some of the social determinants of health that we encounter on a daily basis are listed here. I think those probably don't need much more explanation. And I'm sure that the people on this call are fairly familiar with how each of these can impact an individual in a community's health. Certainly for the purposes of this group, involvement with the criminal justice system has no negative health effects on people's health, both while they are incarcerated and afterwards. People with chronic illnesses become more sick, not less sick, when they're in jail and prison. People with substance use disorders are at extremely high risk of overdose if they leave jail or prison without having received treatment. And then looking at some health impacts of being homeless, essentially. So there are both physical and psychiatric health consequences to chronic homelessness. You can see here that every chronic comorbidity that I treat in the clinic as a primary care doctor, that I learned about and trained about in medical school and residency, impacts people who are experiencing homelessness more than people who are housed. And then that disparity is, of course, particularly sharp for things like HIV, hepatitis C, substance use disorders, and mental illness. And then notably, overdose is and has been for the past several years the leading cause of death among people experiencing homelessness nationwide and in Colorado. And I don't see that changing anytime in the near future with the influx of fentanyl into the illicit drug supply. Mental health concerns are very common among people experiencing homelessness. In a survey related to this slide, in this same survey, 55% of all people experiencing homelessness reported some type of severe mental health concern within the last 6 months. Suicide rates among people experiencing homelessness are 10 times higher than in the general population. And a significant number, up to half of people experiencing homelessness, have had thoughts of suicide or have attempted suicide within the last year. And so in order to address these health disparities among people who experience homelessness, we at Stout Street Health Center offer a number of resources and services that are difficult for people experiencing homelessness to access elsewhere in the community. We offer primary care, behavioral health, pediatrics, dental, vision. We have our own pharmacy and lab. We have enrollment specialists to help people get set up in Medicaid so they can access care more broadly. We have a number of healthcare centers, both our primary brick and mortar center as well as shelter-based clinics. We have a mobile clinic that goes around to day shelters weekly and provides health services in the community. And then we have street outreach, which accesses folks who are unsheltered living in encampments throughout downtown and the surrounding areas and offers healthcare resources and services to them on the street. Particularly for people who experience homelessness, there are persistent disparities in access to things like vision care and dental care. And so I think we're very proud to offer both of those things free of charge, no need for insurance to anybody who walks in the door at Stout Street Health Center. And most of our patients have not had any of those types of services in years to decades prior to accessing care with us. And then I'll talk a little bit about street medicine, which is close to my heart and which is kind of my baby at Stout Street. So we have a small team of nurses and doctors, doctor being me and the nurses being 2 street outreach nurses that I work with. And we are able to access people who are living on the streets, staying in encampments around downtown, and offer them medical services where they are. this program exists out of the realization, it was born out of the realization that despite being as low threshold as possible, and despite designing our entire Stout Street Health Center with the needs of people experiencing homelessness in mind and making it as safe and accessible to them as humanly possible, there is still a subset of our patients who will never ever access care there. And that is for valid reasons. There's a subset of people experiencing homelessness on the streets whose personal experiences involve such severe healthcare trauma, severe persistent mental illness, substance use disorder, and the fear of entering withdrawal, that they will not enter a healthcare setting unless it is a life and death emergency. People who are living on the streets, staying in tents, are very, very reluctant to leave their tents to access medical care for fear that when they return to their tents, they will have been swept away and everything that they own will have been gone, or they will have been robbed, or the city will have moved or relocated or thrown out their tent and all of their belongings. They are very reluctant to leave their partners who they rely on very deeply. They're reluctant to leave their pets who are their family and their support systems. They're afraid of violence in the area of the clinic, of trauma, of arrest, and they're terrified that we're going to warrant check them despite our reassurances, and they don't want to come access any formalized services anywhere where they could possibly be swept up by the carceral systems. And so we are, in our attempt to meet people where they're at, going into the encampments, building relationships with people there, building trust, trying to rebuild trust in the medical system or in some type of formal social service agency that can offer them help, and offering them medical care such as triage of acute medical issues, basic primary care, help like with diabetes and high blood pressure, referral back to the healthcare system for those who are willing to present to Stout Street Health Center for a little bit more of a thorough workup. Wound care on the streets is a big one, treating cellulitis and other skin and soft tissue infections, and basically trying to use medical services, not only to provide medical services, but also as a bridge to building that relationship so that possibly the third, the fourth, the fifth time that we encourage them to come to Stout Street Health Center to engage with full medical care, full psychiatric, dental, vision, case management, they might be a little bit more willing to. And sometimes it takes 2 encounters with someone, sometimes it takes 20 encounters with someone, and sometimes it will never happen. But we know that they will not come to us at Stout Street Health Center, and we feel obligated, and that it is our mission to bring care to them to the best of our ability. And the care that we bring to them is founded in a couple of principles of street medicine and also of healthcare for the homeless in general, including trauma-informed care. There is an old saying that not all homelessness is caused by trauma, but all homelessness results in trauma. And even just spending one night on the streets with no way to keep yourself safe is incredibly traumatizing. And so approaching people gently with concern for their goals and being mindful of the reasons why they may be very understandably mistrustful and fearful of interacting with any type of formalized societal system is one of the tenets of trauma-informed care that we try to live and breathe. Motivational interviewing, which is more of a sort of clinical tool that we use to help people identify and meet their goals. We practice harm reduction, particularly in my work in the substance use disorder clinic. We are not an abstinence-based, an abstinence-only program. We will support people in at whatever spot, at whatever location in the spectrum of use they are. And the spectrum of use ranges all the way from very chaotic, very harmful drug use through managed use, through reduced use, through recovery and abstinence. So wherever people present, we will meet them non-judgmentally, and we will help them make any step towards positive change. So if you're interested in getting more involved or learning more, you'll have my contact information, and I would love to hear from you. I'll be happy to take questions. And we are around in the social media sphere, online, and there's many ways to connect with us. So I think that was actually a bit less than 20 minutes. Hopefully we've got time for questions, and I will stop my screen share.
Thank you so much, Dr. Axelrath, for your great work and your commitment to harm reduction and humanity. And we definitely have time for questions. So people can speak up or put things in the chat and I'll relay them along. And can I ask, how long have you been doing the street clinic work?
I started with Colorado Coalition for the Homeless August of 2021, so just over about a year. We as an organization have been really practicing street medicine in a more coordinated and organized way for probably about the last 3 years, about a year and a half before I arrived. And before I arrived, it remains a nurse-driven, nurse-led program, as is sort of the history and tradition of street medicine, founded in Pittsburgh and Boston in the 1980s and 90s. It was founded as kind of a nurse-led initiative, and it remains that way, but they've had some provider support from myself and then others who fill in occasionally for about the last year and a half. And prior to that, Colorado Coalition for the Homeless had been trying different ways of doing street medicine and had not had great success with engagement. And I think we've realized that the key difference now is consistency and regularity. And now that they are seeing my face on the streets every week, and it's not rotating voluntary providers, I actually get paid to do this work. It's part of my job. It's part of my FTE. They are seeing my face on the streets, and I'm able to build that relationship with them over time on the streets. And so there are now people I've known for a year and a half on the streets who I've never seen in clinic. And when I am able to get them into clinic, I'm able to refer them to myself. So I can tell them, I know you have a lot of concerns about coming into the clinic. How can I reassure you? And the biggest thing that I think can reassure people is that they know that they're going to see the same person on the streets as then when they come into the clinic for their appointment.
And following up to that, how often, when you're out going to different sites, what percentage of folks that you're seeing are folks you're seeing again for that continuity versus new faces, people that you've never encountered before? What's the balance there?
I'd say it's about 50-50, and that's actually not too different than the balance in our clinic. As a primary care doctor, I want to have my own panel. I want to get to know people over time. That's really part of what makes it rewarding. And that's just not possible in this patient population the way that it is in my own Kaiser primary care practice. Although I will say I've had 3 different Kaiser primary care doctors, so it's not perfect anywhere in the healthcare system. So I see about half the time it's people that I'm seeing again, maybe who I haven't seen for several months and we're reconnecting. And about half of the time it's people that I am meeting for the first time, most of whom have not been connected to any type of medical care for years.
Thank you. And here's a question in the chat. Sonia Burns asks, for the long-term dual diagnosis residential care, how is that funded? And is there a time limit? Great
question. I couldn't tell you off the top of my head how it's funded, although I can get that information. I don't work with that program specifically. I imagine that it comes from CCH general funds, which are a hodgepodge of some federal funds, some state funds, and then a lot of private and grant funds. But I can get more specific information about that. And it's generally a 2-year time limit. So folks can stay there up to 2 years while they work on their sobriety, participate in groups, get counseling, get medical care, get vocational training, work with case managers to get set up with permanent supportive housing, and are given about 2 years to complete all of those tasks. And I would say it takes 2 years to complete many of those tasks, particularly the housing.
Thank you. And here's another question from Alyssa Witt in Gilpin County, who asks, is the 1-year definition of being unhoused a criteria for services, or does recent eviction qualify for services?
Good question. And thanks for letting me clarify that the 1-year definition of being unhoused is how we define chronic homelessness. And that's mostly for purposes of information gathering, demographic gathering, and research. So after 1 year, we put people in that category of chronically homeless, and we look at them a little bit separately as a group when we're looking at our demographics and sort of designing programs to serve different subpopulations' needs. But to receive services, as far as I know, certainly at Colorado Coalition for the Homeless, at Stout Street, and I also think through at most of the homeless services providers that I'm aware of in Denver, including St. Francis Center and other Urban Peak and other places, there is no time limit requirement on homelessness. Somebody who got evicted the night before could present for care and receive all the same services.
Great, thank you. So you had mentioned that much of the work that you do in going back to the same sites is about establishing or reestablishing trust in healthcare systems, and how wary people are about warrant checks and things like that. Have you had any challenging issues in what are the sorts of challenges around establishing that trust and reassuring folks that this is not about warrant checks or those other contacts with the system that are undesirable from their perspective?
Yeah, I think that's the work. That is the challenge. Frankly, what I do on the streets in terms of medical care is not practicing medicine at the highest level that I am able to because of limited resources. But the more valuable thing that we do on the streets is we build that relationship so that people can access medical care in more traditional settings in the future, or hopefully. And people have a great amount of fear around interacting with any type of formal social service that they think may link them into the carceral system. And that includes certainly healthcare. And I think actually healthcare is one of the worst offenders in that realm. And people have been warrant checked in emergency rooms. We wish that it wouldn't happen, but it does happen. And they're right when they say that it happens, and they're right to be afraid of it. We certainly don't do that at Stout Street, but they have no reason to believe me when I say that, because they've been burned before and they've had bad outcomes before, or they've heard of other people who have. So the only thing that we can really do is walk the walk, and we can tell them until we turn blue in the face that we're not going to warrant check them. We're not going to search their bags. We're not going to confiscate their drugs. We're not about that. We're truly only here to provide healthcare related services. But until we have an opportunity to prove ourselves to people in practice, and realistically to prove ourselves multiple times, that trust is going to be really hard to rebuild. And so the way that we rebuild that trust is that we do what we say we're going to do. So if we say we're going to provide a service, we do. If we say we're going to meet them somewhere, we do. If we say that we can find them a pair of shoes, we better find them that pair of shoes. And it's really, really small things like that over time, consistently, that build back a little bit of trust. And then it's also wanting to, it's not enough for them to trust me because I'm only out on the streets once a week, and I may not be doing this work forever. Somebody else may take my place at some point. And the goal is really to help them trust the system as a whole. And so trusting me or trusting the nurse that I work with is the first step. And then slowly introducing them to the clinic, which could be as simple as walking them to the front door and just letting them look at the clinic. And then the next time, maybe they come inside and they take a seat and they get a snack. And it can be an incredibly slow process. But these are people with really deep and profound trauma, and they've been hurt by the medical system in the past. They've really been harmed by by medical systems that have not had their best interests at heart all of the time. So yeah, that was a long rambling answer to the question, but it's just to say that they're right to be scared, and we have to earn back that trust.
Thank you. So another question from the chat. For the ACT teams, are people ever dropped for refusal to engage?
That is a very good question that I don't have a very clear answer to. I know that the ACT model is very kind of protocolized and very detailed. And so I know that we try to practice fidelity to that model to the best of our ability, but I don't know all the details because I don't work directly with the ACT team. So again, I could put you in touch with somebody who is more involved with the ACT team, and they could probably talk more specifically about our actual protocols.
Great, thank you so much. Any more questions from anyone?
I do have one more question. I'm sorry.
That's all right. Please go ahead.
So I've worked some with Dr. Susan Partovi, who does something similar to what you're doing in LA County. And I don't know if Colorado has been like watching what's happening there, but Colorado is, pushing that CARE Act, which is basically now we're going to conserve people who are homeless and have mental health issues and kind of, I don't know, I guess it's the alternative to knowing that they're just going to keep cycling through the systems, right? Of course, they don't have money on the back end. They put money in the front end to the court system, but then you're supposed to like get housing and care. But I'm just wondering, in your interactions with people, so I'm in Austin, Texas, and I'm about to meet with someone who's similar to you here after this meeting. And we've been talking a lot about like the IDD populations, the TBI populations, like people who really like will never be able to navigate systems on their own. Like they really do need help. But I'm just wondering what Colorado, Denver, like might think about the California approach, but just like what you see in those rooms where people really aren't able to navigate the world on their own. And then they're left to the streets, and luckily have you to help them.
That's a great question. I guess I will start by saying that upfront that I think that the majority of people experiencing homelessness, even those experiencing chronically homelessness can be housed. And they can be housed with a very intensive, very labor intensive, very multidisciplinary, very individualized plan of care that meets their needs. And they may not be able to work. They may rely on social services and benefits, and that is what those systems are there for. And there's a small population of people, particularly people with severe TBIs, like you mentioned, overlapping with chronic mental illness, overlapping with severe substance use disorders, who may never be able to achieve sort of the level of stability to live independently, right? We may be able to house them, but that they may not thrive in that setting because they just can't meet their own daily needs. They need more support than we're able to provide through the ACT model or something like that. And that has come up, and we don't have, as a society, a good solution for those people right now. I think there is, as you're saying, there is this sort of push to almost kind of warehouse people and to just find a simple solution and put people in a place. And they are different, I guess, different municipalities or funders are willing to fund that on the front end. But then, as you're saying, the back end is left kind of open-ended. And, on a large scale, I would say that we do need a humane, compassionate place for people who cannot live on their own independently, where they can actually thrive and be productive. And that we as a society, we don't have that for anybody really as a society. We don't have that for people experiencing homelessness, the folks that you're talking about. We don't have that for people who are elderly. We don't have that for veterans. We don't have that for anybody. The best thing that we have is nursing homes and skilled nursing facilities or SNFs, where people can get sort of their ADLs and their activities of daily living managed, but they're not exactly sort of thriving communities and the types of peer supported group living communities that I think most people would prefer. So I don't have a clear solution to that, but I appreciate the question. And I wish that we had better options for people who can't live independently, but who still want and deserve to thrive and be productive and not just be warehoused away.
Thank you. Yeah, no, that is exactly the gap in our continuum of uncaring. And more communities need to devote themselves to creating that permanent supportive housing type array of services for individuals rather than just letting them fall through the cracks repeatedly. So thank you so much for putting that so clearly. Any final questions? Well, seeing none, we will wrap things up for today. And I'm sure Dr. Axelrath will be available if anybody has follow-up questions. Just let us know and we can put you in touch. Thank you so much for joining us, and look forward to seeing you next time. Wishing everybody a happy Thanksgiving.
Thank you very much, everybody. I really appreciate your time.